So today we have a little different kind of session in the sense that we are keeping a few landmark studies which have changed the treatment management recently in some of the uro-oncology cases. So today we have our second year resident, Dr. Nirav Mehta, who would present these studies. And the moderator of the session would be Dr. R.D. Sahu. And we have a special invitee today with us, Dr. Rajiv Sood. So Dr. Rajiv Sood doesn't need any introduction. So I've just left it blank because he has been president of almost all the medical associations in the country. And he has been given the award of Padma Shri also for his exemplary work in this field. He was the ex-dean and the HOD of RML Hospital also. And he presently has been given also as a membership of the National Medical Council uh, as a part of the Delhi Medical Society. So welcome, Dr. Rajiv Sood. Have you joined us, sir? So Dr. Rajiv Sood would be joining us soon. So in the meantime, I would request our moderator today, Dr. R.D. Sahu, to invite the presenter and start the session, please.
Thank you, sir. Thank you, sir. Thank you, Rajiv, sir. Please.
R.D., your sound is very feeble. Yes, yes. Go ahead.
Dr. Nirav, please start your presentation.
Good evening, sir. Is my screen visible, sir?
Yes. So make it full screen, please.
Yes. Is it okay now? Is it visible full screen, sir?
Yes, yes. Thank you.
Okay.
Go ahead.
Thank you, sir. Should I start, sir?
Yes. Yes, you can go ahead.
Okay, sir. Good evening, respected teachers, senior colleagues, and juniors. Today we are going to discuss about landmark studies and recent studies in uro-oncology. So starting with the first trial, Checkmate Trial 214. It is a trial for the medical management of the clear cell variant of the metastatic renal cell carcinoma. It is a randomized phase 3 control trial between the immune checkpoint inhibitor and the sunitinib. More than 1,000 subjects were randomized in a two group between the combination of nivolumab plus ipilimumab and the sunitinib. The primary endpoints were overall survival, objective response rate, and progression-free survival. The study shows significant survival benefit with the immune checkpoint inhibitor combination. At the 18 month, it shows around 15% of survival advantage over the sunitinib, and the median survival was not reached in the immune checkpoint inhibitor group, with median survival was reached at 26 months in the sunitinib group. It also showed the progression-free survival advantage. And based upon this, this was accepted in EAU also as recently as a standard of care first-line management in intermediate to poor risk patient of metastatic clear cell RCC. It shows all three primary. It fulfilled all three primary endpoints, and overall progression-free and objective response rates were better than sunitinib in the study. Another one study is the Keynote 426 trial, which is it is again a randomized trial between pembrolizumab and axitinib combination versus sunitinib. The base of the trial was on the basis of superior efficacy of the combination of pembrolizumab and axitinib in a small scale study, and they decided to carry the long-term efficacy and safety of the combination against the sunitinib. So this trial was carried out. It is again a randomized trial, and more than 850 patients were randomized in a two group, and it showed the progression free as well as overall survival rate in the group, in the study group, in comparison to the sunitinib. And it has also been accepted in EAU guideline as a standard of care first-line management in both favorable and intermediate to high-risk patients of metastatic clear cell RCC. These were the trial results, and these are the EAU guideline as a first-line management in the favorable and intermediate and poor-risk patient. Pembrolizumab plus axitinib has been accepted as a standard of care in first line, and the nivolumab plus ipilimumab has been accepted as a first line in intermediate to poor risk patient. And the immune checkpoint inhibitors are also accepted in EU as a second line management in patients who have taken prior tyrosine kinase inhibitor. Nivolumab is accepted for the second line in EU guidelines. Talking about another trial, this is a phase 2 trial, Raptor trial for the everolimus in case of papillary variant of the RCC. Papillary histology is accounts for 10 to 15% of the renal cell carcinoma, and the treatment option for this histology are very limited in the recent era. So the trial was carried as a non-randomized single-arm trial, and the everolimus was given 10 mg once daily. And the primary endpoint was progression-free survival for the patients. It showed both progression-free as well as overall survival benefit, and it is at limited level. It is benefited in the patients with papillary metastatic RCC in median progression-free and overall survival. Next one is, this is a phase 2 trial of the intravesical gemcitabine. This has cleared the phase 2 and going on in the phase 3 trial. This is trial for the intravesical gemcitabine in patient who have recurred after BCG in non-metastatic bladder cancer, intermediate to high risk patient. According to the EU guideline at present, the BCG adjuvant intravesical BCG is the standard of care in the intermediate and poor risk patient of the non-muscle invasive bladder cancer. And following BCG recurrence, we have two options: either restart the induction again or early cystectomy. But the patients which are not eligible for the early cystectomy, this trial was aimed at the benefiting for those patients. In this trial, 2 gram of gemcitabine was given 100 ml NS weekly for the 6 weeks and followed by maintenance dose of monthly for 12 months. The primary outcome was, primary endpoint was kept as complete response rate and this was decided on the basis of cystoscopy, urine cytology, and bladder biopsy. Secondary endpoints were overall and progression-free survival rate. The trial showed result of 47% complete response at 3 months and around 20% the 2 years response. And this is going on in phase 3. Intravesical gemcitabine may be an option for a BCG recurrent patient in future for the non-muscle invasive bladder cancer. This trial is a landmark trial, Nordic 2 trial for the neoadjuvant chemotherapy in metastatic bladder cancer. Before the trial, standard of care was radical cystectomy, and the results for radical cystectomy were 50% 5-year survival. The trial was aimed at improving the survival with addition of neoadjuvant chemotherapy. This was tested with cisplatin and methotrexate combination. And this trial showed, this was again randomized trial, around 310 patients were randomized, and this showed around 5 to 7% improvement in the survival with neoadjuvant chemotherapy. The rest other trials following this trial were also done, and all that showed 5 to 8% survival. Following this trial, recently one of the trial was carried out. This was the trial. This was a meta-analysis of multiple RCTs for the solidification of the results of that Nordic trial of advantage of neoadjuvant chemotherapy. Around 15 RCTs were analyzed for the comparing the neoadjuvant chemotherapy with the local treatment, and around 13 retrospective studies were analyzed for comparing MVAC therapy with the gemcitabine cisplatin. Around 1,300 articles were reviewed, and all were by screening all that, eligible articles were included in the study, and it showed survival advantage of definite 8% survival advantage in neoadjuvant chemotherapy with better survival advantage with combination of gemcitabine and cisplatin. Cisplatin gemcitabine combination showed definite overall survival benefit with neoadjuvant chemotherapy in muscle invasive bladder cancer. And on the basis of this, AAU guideline has recently added this as a standard of care in muscle invasive bladder cancer. Another new trial is a pembrolizumab in neoadjuvant chemotherapy. This is a pure 01 trial. This again has passed phase 2, and this was for the patients who are positive for PD-1 receptors on the T cells. Pembrolizumab was given once in 3 weekly for 3 cycles before the radical cystectomy, and primary endpoints was complete response rate again. And in the result, they found in pembrolizumab patients low tumor mutation burden and high PD-1 combined scores, which was favorable for the cancer survival. And it showed 42% of the complete response rate in the patient when used in eligible patients. So this may again be in future be a option for the platinum ineligible patient as a neoadjuvant chemotherapy in muscle invasive bladder cancers. This is the recent AU guidelines for the muscle invasive bladder cancer. Neoadjuvant chemotherapy based on cisplatin if patient is fit for that, followed by radical cystectomy and adjuvant therapy in high risk patients. This is again the EAU guidelines showing same neoadjuvant chemotherapy, radical cystectomy, and adjuvant therapies. This is again a new next trial, Keynote 045. This is the trial for the medical management second line treatment in the metastatic CA bladder. Before this, second line chemotherapy were used in patients who have failed after the GC platinum based chemotherapy in metastatic CA bladder. This again is a randomized phase 3 trial, and more than 550 patients were enrolled in the trial, and the primary endpoint were overall and progression-free survival. Then pembrolizumab as a second-line agent showed both the survival overall and progression-free survival rate in the trial, and is been accepted by UAE as a second-line agent in the platinum recurred patient in metastatic CA bladder. This is the EU guideline, and second-line therapy pembrolizumab has been accepted. This again is a EU guideline, and as a second-line treatment, immune checkpoint inhibitor pembrolizumab has been accepted in guideline based on trial. Next one is a STEMPED trial. This is a landmark open label multi-arm and multi-stage trial. This is going on in multiple. There are multiple arms of this trial. We are going to discuss two important arms of the trial. This is arm E, which is for the upfront chemotherapy in case of metastatic hormone sensitive CA prostate. The base of the trial was that for very long, the hormone therapy was the only option for the metastatic CA prostate, and they wanted to test the addition of treatment in hormonal therapy to check for any overall improvement in survival by adding any other treatments. So in STEMPED, they divided into four arms in androgen deprivation therapy alone, androgen deprivation therapy associated with zoledronic acid, androgen deprivation therapy with docetaxel, and combination of all of three. And the patients with docetaxel show mostly the overall and progression-free survival. So docetaxel showed definite 10-month overall survival in the patients by adding into hormonal therapy. So based upon the trial, docetaxel was accepted as a upfront chemotherapy eligible for the patients in the EU guidelines also. Other landmark trial Charted has also supported the same result, and on the basis of both this, upfront chemotherapy in metastatic hormone sensitive patient has been accepted. Next one is arm C for the upfront abiraterone therapy. The basis of the trial was that the important mechanism for escape of androgen ablation in CA prostate was believed to be the intracellular conversion of steroid precursor to the androgenic steroid by prostatic cancer cell. And abiraterone irreversibly inhibit the enzyme CYP17, which is important for the conversion of the steroid to the androgens. This was again a randomized trial. Total more than 1900 patients were enrolled in the trial, and they were divided in two groups of androgen therapy alone with androgen therapy plus abiraterone plus prednisolone. Primary outcome was overall survival, and intermediate outcome was failure-free survival. And abiraterone saw significant high overall as well as progression-free and failure-free survival in the trial. And the results of abiraterone showed 71% improvement in the treatment, and that translated into 37% of overall survival in patients with abiraterone plus prednisolone combination with hormonal therapy in patient of metastatic hormone sensitive. Another one the strength of this trial was that it was conducted on a large number of subjects. More than 3,000 patients were included, and the data was very recent, and long follow-up were taken. Around 43-month follow-up were taken for the patients in STEMPED trial. Also, the patients were taken from the varied area and large geographic area, so that can be generalized. The results can be generalized in the patients, and the compliance of the patient for the treatment in the trial was good. Talking about the limitation of the trial, that limitation with proportion of the patients not starting the especially docetaxel therapy. Docetaxel was disaggregated by multiple number of the patients, and impact of other therapy. Patient taking other therapies that does not affect the hormone receptor were also violated the results of the trial to some extent. And the power of consistency was low of the trial, and the result of many patients died due to the coexisting disease that were not counted in the trial, and the short-term follow-up for older patients. Older patients lived for less, and that was not also taken into the consideration in the trial. And also the trial laid the dilemma for the primary standard of care in patient of metastatic hormone sensitive between the abiraterone and docetaxel, as both were found to be significant, but the abiraterone was better in terms of drug delivery, mode of delivery of the drug, and also side effect profile was better with the abiraterone. And the base of this trial and also another landmark trial, latitude, abiraterone was also accepted as one of the standard of care management as upfront chemotherapy in hormone sensitive metastatic prostate cancer. Based upon these two trials, the abiraterone and docetaxel both were included as upfront chemotherapy accepted in EU guidelines. And the next one is a profound trial for the PARP inhibitors in case of metastatic castration resistant prostate cancer. One of the mechanism for the cancer cells for the DNA repair was the PARP receptor. This PARP receptor help in the DNA repair for the cancer cells. The PARP inhibitor inhibits the receptor and that cause lysis of the tumor cell. So this was randomized trial phase 3 between the olaparib PARP inhibitor versus the patients of enzalutamide or abiraterone failed patient in metastatic CRPC patient. But the patients also had the pre-decided number of DNA mutations. 15 DNA mutations were pre-decided, and the patient who having this mutation were qualified for the trial. The primary endpoint for the trial was progression-free survival, and it showed definite progression-free as well as some of the overall survival benefit also in patients who were progressive on enzalutamide or abiraterone and having the pre-decided mutations. Based upon the trial, olaparib has also been accepted by EU guidelines as a treatment option in patients who have progressed over abiraterone or enzalutamide in metastatic CRPC. And these were some of the important landmark trials for metastatic CRPC. TAX 327 was the docetaxel for the metastatic CRPC. COU 302 was the trial for the docetaxel naive patient in metastatic CRPC. COU 301 was the trial for the post-docetaxel in metastatic CRPC and so survival advantage. TROPIC trial was as a second line in for the cabazitaxel in the post-docetaxel in metastatic CRPC. AFFIRM trial was for enzalutamide for the second line therapy agent in the metastatic CRPC. And this is last the PARP inhibitors profound trial showed the advantage over the in patients who have progressed over the abiraterone or enzalutamide in patients with metastatic CRPC. Based upon the guidelines, the metastatic CRPC, the agent of choice is selected on the basis of performance status, symptom, comorbidity, and to some extent of the disease and genomic profile of the patient. This all the drugs, abiraterone, cabazitaxel, docetaxel, enzalutamide, olaparib are selected on the basis of this criteria. And as we discussed, on the basis of profound trial, PARP inhibitor has also accepted by the EU guideline as a treatment option for the patient of metastatic CRPC who have progressed over abiraterone or enzalutamide, depending upon their DNA gene analysis. Thank you, sir.
Thank you, Nirav. So now I request our invitee, Dr. Rajiv Sood. Dr. Sood, sir, thank you for sparing your valuable time and to coming to our teaching session. It's a real privilege to have you with us. And I know that yes, sir. And I know that this is a favorite subject of yours also. The immunotherapy in the various uro-oncological malignant tumors and other. what are your comments on these studies? And then we will take up one study at a time and then discuss it. So welcome, sir, and please give your comments. Yes.
Actually, these all studies, as you know, we are discussing already. He has very comprehensively presented. These are all ongoing information, and also the understanding is maturing. Guidelines are changing, and with the versions every year we are finding the guidelines are too many places it is improved, because too many trials are going on. There is sea change in the understanding of that immunotherapy, as you are saying, immune check inhibitors, and also the germline testing. That is also has become come in a big way, and it has become the part of the guidelines in EAU, but with the weaker recommendation, weak strength recommendation. But yes, it will become strong strength recommendation once we are our data mature, and also it is become affordable. So you know that we started with the nivolumab and epilumab and versus sunitinib. Sunitinib was a game changer as the target therapy, as the first you have checkmate 214 study you have mentioned. And in that, what has happened, that there is significant improvement in the overall survival, and the side effects were also epilumab had some of the side effects, but nivolumab now many places, many centers may be off level, or maybe after because of non-availability of epilumab. We are giving that immune check inhibitor, and we are finding very good results in renal cancers. And I have my own patients. We don't have the long series, but our patients, like 5 to 6 patients, out of that, even after 5 years, my 2 patients are surviving. So this is something which is phenomenal after failure of so many lines. And even monotherapy nivolumab is also working. Here we have the discussed today the trial where we are giving the combination of IO, that is ipilimumab and nivolumab. So that is the status of immune check inhibitors. And when you go to the prostate cancer,
Can we just discuss this RCC first? So
okay.
let's, because I think, yes, RCC in metastatic RCC with the advent of immunotherapy, Nachiket, say anything? Okay, so Nachiket, please mute yourself. Yes. So, advent of this immune checkpoint inhibitors, definitely the standard of care has changed, and many of these guidelines have changed. And TKIs to this newer drugs, nivolumab, etc. So do you think in our country also this has become the standard of care now for metastatic RCC? And is this drug easily available? And what is the exact cost? And do we have any clinical trials going on so that some of our patients can be put on these clinical trials?
See, at present, clinical trials are not going on, and especially when the COVID protocols are going on for last 1.5 years, there was a real setback, and the recruitments are also suffering. Now you are asking that in our country, what is the status of availability? I told you nivolumab is very easily available. It is cost, of course, it is costing, but there are schemes of 1+1 or 1+2, and the cost has come down. If you buy one, maybe of 1.4 lakh, then after 15 days you get the second dose free. You have to fill the form. The practitioner, the treating oncologist or treating physician has to fill the certain forms, and it is available. It is not available freely in the insurance sector. It is not available in the Ayushman Bharat also. You can recommend, but you know that your whole amount of 5 lakh or for economically weaker section or for the low income groups, that is facilities there from Ministry of Health, and the upper limit is 5 lakh rupees. So in all this, it will be the whole limit will be exhausted if you start these things. But then you have target therapy. It is not that that is not first line. That is also first line. Now, how we have evolved? We were giving the target therapy as the first line recently. Then we were choosing whether to give sunitinib or to pazopanib. There were compared trial and all. After that, we found that non-inferiority trials were done. And after coming out of these non-inferiority trials, when these immune check inhibitors came, and one thing good is this, unlike pembrolizumab, where the PD-L1 status is to be checked, nivolumab is giving good results in PD-L1 positive and negative both the populations, and therefore these immunocheck inhibitors have been widely used, and as a monotherapy also in many centers they are used. So that is why I am saying that availability is there. If you want, it is easily available, but the cost is still, it has become 50. It was around more than 2 lakh, or rather 3 lakh, then it came to 1.40 lakh, and now it is 50% of that. So it is continuously coming down.
How long it has to be given, and what is the total cost if suppose if the patient is taking lifelong, what is the total cost?
See, immune check inhibitors, initially there is a pseudo-tumor progression effect also. And therefore, even if there is, after giving, you see that in the RECIST criteria, in the measurements, if the tumor size seems to be increased, that is not actual increase, because there is infiltration by the this immune cells also in the tumor, and it is swelled, and after that it start giving response. Exact response it is giving, we realize in 3 months, and in patients it is usually given around 2 years, and if a patient is doing very well, because there are chances of complete response also. And that is unlike, there is a chance of complete response, but very small percentage in sunitinib or pazopanib. But this one agent has come, immune check inhibitor, where complete response is possible. And after this nivolumab, there is another combination, and that is very interesting. That combination is pembrolizumab, and where we add the target therapy like axitinib tablets to that. And you know that after sunitinib was failing 3 times, beneficial was shown axitinib in head-on trials. And now what has happened, that when we are giving pembrolizumab and axitinib, there is no head-on trial with this combination versus IOT combination. But it has been found that the survival benefits are more with pembrolizumab and axitinib, but that is very costly. That cost is going almost double the nivolumab. Nivolumab has been used in many other malignancies like lung malignancy, or almost many malignancy it is used, even head and neck and all, and oncologists are right and left using, and that cost is also coming down. And same thing is happening with pembrolizumab also. There is a multi-endocrine deficiencies with these agents, because they are not only, they may attack the endocrine system, and there may be hypothyroidism, there may be the adrenal may be attacked, there may be so many deficiencies, and therefore you have to be careful, and it is more with the pembrolizumab. So we are using now immune check inhibitors more and more. If the patient can afford, this is the first line choice.
We know that there is a risk stratification also. We have to stratify these into either high risk low risk and intermediate risk. And then according to the biopsy report also, if it is non-clear cell or a clear cell carcinoma. So how do you actually give these to the different types of this population?
See, there are three types of risk things:
Right.
favorable,
Yeah.
and then intermediate, and then the poor risk.
Yes.
In intermediate and poor risk, we are giving, and then
Okay.
where you are not able to give, then sunitinib is alternate, or as the first line always is available with you. And therefore, you have to assess, that for sunitinib also the basic parameters you have to see, and then whether sunitinib is more safe or pazopanib is more safe, we were discussing. And similarly now, with the different histological variants also of renal tumors, it has been used in almost all the variants, the immune check inhibitors also. And therefore, it is not out of the context to use this for the intermediate and poor risk also.
The only thing is that in one of the studies, they showed that with papillary carcinoma, probably everolimus is still probably one of the choices rather than giving him.
These opinions are there, papillary carcinoma, but everolimus versus immune check inhibitors, the head-on studies are not there. But everolimus, the effect has been seen and it was given. And if you remember, around 8 to 10 years back, sarcoid differentiation, if it is there, then even sorafenib was used. And some of the oncologists, even in Delhi, they are still using that. But others have cited the examples of the trials, head-on trials, where they have now proved that it is as good as placebo. So, but in our practice, we are even to the poor patients, we are giving, still giving, and now sunitinib has also generic has come. So we will replace for them also now. Now no more sorafenib will be used.
Right. So only thing is amongst between the two, pazopanib and sunitinib, how do you decide which to give?
See, we see the safety profile because sunitinib is good, time-tested, and maximum clinical scenarios and maximum trials sunitinib has proved to be uniformly, consistently effective. And this is one drug which is consistently effective. Pazopanib has less side effects, and it has some problem of liver enzymes raising, but that is not very serious. And we have not done superiority trial, we have done the inferiority, non-inferior trial, and it has been found. And but there is a pigmentation, hypopigmentation, like the hair becomes white, the eyebrows become white, the skin become pale, and the patient, many patients, they don't like the situation. It is safer, but because of these non-harmful side effects, sometimes a patient is not accepting it. But if sunitinib is not tolerable or not, we give pazopanib, and many of the oncologists upfront are choosing pazopanib.
Right, because now sunitinib has become very cheap, so probably this for
not
most
only
of the
sunitinib, now pazopanib, the generic is also almost it is in the market. And now this, because you know that when next generation comes, the previous generation becomes cheaper, because now immune check inhibitors have been proven that they are the much better choice. So all the target therapies, you will see that their price cost will come down. Even axitinib generic has come, and their choice, their price is also coming down.
right. The second study was about the intravesical gemcitabine. particularly in the patients who have failed with intravesical BCG in high-grade, high-risk patients of malignancy, non-muscle invasive bladder tumor. So, what do you think about intravesical gemcitabine? So, previously the choice was either give repeat BCG induction therapy or sometimes intravesical mitomycin or with the HIVEC therapy. And now we have intravesical gemcitabine. So, what are
As,
your
as you have seen in the study, the intravesical gemcitabine has also given good results. And now it is in NCCN guidelines were the first which accepted it as the first line. Now, you know, when we are talking about intravesical therapy, we have two scenarios. One scenario is you are giving intravesical immunotherapy, T cell mediated, that is BCG. Or there were interferons also. Interferons were very costly, so they were not popular. But initially, we were giving BCG intolerability. We were reducing the dose of BCG. There were some trials, but they never came in guidelines. And like 1/3 of the dose you do, and after that you add interferon, but large doses, and it was not cost effective to gain that. So then came that intravesical chemotherapy. In many, that so many agents have been tried in the past, but mitomycin C gained the popularity. And now the thing was that the progression of disease was supposed to be not controlled initially by intravesical chemotherapy, but BCG was effective for preventing the progression of disease also. But later it was found that after TURBT, if you instill the dose of mitomycin at that time, and then it is so effective that significantly it is reducing the recurrences. So single dose we started giving if the blood tinge is not there and it is not hematuria. But now what has happened, there is global shortage of BCG. It is very important. You know that Danish strain has gone, the Novartis BCG has gone, Oncotyce is not available. And one by one in the global scenario, BCG is less and less available. Now what is happening, that Onco BCG started, and Pune Institute, Serum Institute, they manufactured. And after that, it was found it was compared with the conventional BCG. It was found that it is less tolerable, and therefore trials were done of 80 milligram versus 120 milligram doses in lamresin, and ultimately it was found that efficacy is not compromised. So now the standard dose with the current available BCG, which is actually 120, but now it has become 80 milligram, and 80, but 40 is not that effective. So we switched to 80. But now when HIVEC you mentioned, when HIVEC came, then in that case the HIVEC started giving the better penetration in the tissues. Like when we freshly resect, the tissue penetration is there. That's why when it is large tumors and muscle invasive or there is perforation, we don't give mitomycin. But we want the penetration. Now this penetration increased by increasing the temperature. So that effect was there, and it was found that it is equal to BCG. It is not equal, it is non-inferior to BCG. And it was effective in progression of the disease also. And now, what has happened after that? Gemcitabine, like I am using gemcitabine off-label for around 15 years. When it is BCG intolerant tumors were there, we were giving gemcitabine was available free of cost in our hospital. So, but the large dose is to be given. So 2 gram you are putting every time. Earlier, you know, when Gemsite was there, it was very costly. Now gemcitabine also gradually the cost came down and we started using. And it is now used globally, and now trials have shown that gemcitabine is non-inferior to mitomycin C. And now even in our institution, the trial is going on, and in All India Institute also, we are comparing 3 arms. The one is BCG, because in India it is available, so we can use it. It's supplied by Cipla, manufactured by Serum India. And also then in compared to BCG, HIVAC also we are giving the second arm, and third arm gemcitabine. And our experience, off-label experience of last 10 years or 15 years shows that gemcitabine is quite effective. And the actual results will come now. It has come in small trials, it has come, and it has gained entry in the guidelines also. And more and more papers are being published. And amongst all other chemotherapies intravesical, gemcitabine is the next which has less side effect. Even side effects are lesser than mitomycin. So we are switching to gemcitabine wherever it is required.
So maybe in high-grade cases, non-muscle invasive, we can directly switch on to intravesical gemcitabine.
That is one more reason also, because in my philosophy was that in any case we are giving gemcitabine cisplatin, and the drug which we are giving, and we are confident it is acting on that, and for IV therapy trials it has been proven. So therefore in intravesical also my thinking was that it will also be effective. So both ways we were giving, and in fact it is not, I'm not teaching that, but what I was doing, I was giving one shot of IV gemcitabine also and cisplatin in the very high risk tumors where, and after that continuing with the intravesical gemcitabine. That also I had done. So, but that is not to be taught. This is not in line, as I was not telling everybody or that you do this gemcitabine intravesical, but now it is in the guideline. So gradually things keeps on changing. It is a evolving science.
So we know that cisplatin is probably one of the best chemotherapeutic drug for CA bladder. Do you think intravesical cisplatin will come in the market sometime? Intravesical cisplatin.
No, cisplatin is a platinum-based. All therapies are their mechanism is such that they are effective intravesically. Oh, sorry, intravenous. And intravenous, and this only not only making the chemotherapy more effective, but it is making the radiotherapy also more sensitive.
Also sensitive, right?
So therefore, platinum-based chemotherapies are not tried intravesically. But I'll share with you immune check inhibitors we are now discussing. Now the trials are going on that you put intravesical immune check inhibitors. So many things are happening. You never know what will happen in the future, but it is not in the near future. Right. I'm not foreseeing that possibility.
Right. So we might have a combination of maybe intravesical BCG and intravesical gemcitabine giving alternately. They might act symmetrically. They may also have a role, maybe we do not know in the future.
Like it is a loud thinking. No trials have been done, but I had been giving BCG where tolerability was less. So BCG alternating with interferon, large doses of interferon. So one cycle I was giving that, and one cycle interferon, I was successful in controlling the intolerability. So these things can come, but you have to have the structural trial. You cannot recommend it.
Right, that's right. Another study that he quoted was about cisplatin methotrexate as a new adjuvant chemotherapy. We know in muscle invasive bladder tumor now, it's almost in the guideline that we need to give a new adjuvant chemotherapy. And this trial showed a combination of cisplatin and methotrexate. Right, Nirav?
So basically the magic is cisplatin only. And you know that it has started now for these tumors, methotrexate and cisplatinum. Combination in All India Institute of Medical Science. See, it was the protocol. There was a thesis long back, 25 years back. And then it was started, not as a new adjuvant, But as those for poor patient, it had started and it was given regularly, and it was the protocol, that departmental protocol, and now it has come when everything else which is effective is being used as neoadjuvant. Then this trial is also giving good insights that this combination can also be used.
So instead of giving MVAC or the dense dose MVAC, we can give this a combination of cisplatin methotrexate also.
We can give actually individualized treatment is there, affordability is also there, and now more and more studies are coming for PDL these checkpoint inhibitors as neoadjuvant, and they are proving to be even more beneficial. So basic concept is that neoadjuvant chemotherapy or neoadjuvant immunotherapy, both are effective, both are giving good results. Now there is no scope of controversy, and this is by circumstantial problems, like in a long waiting list for operating. When this concept came, we started coming, but later on it is routine in our department for last say 20 years, and now it has come in guidelines also, and it has proved. So we were doing offline, and now it has become the
Right, exactly. The next study that he had quoted was the pembrolizumab as neoadjuvant chemotherapy, which was
that is quite
study
effective.
was done on that, right?
Quite effective. Neoadjuvant chemotherapy is quite effective, and that can be used.
Right. Again, the immunotherapy has also been tried as a second line chemotherapy, second line after the chemotherapy. Once
Yes,
the chemotherapy for metastatic carcinoma. Yes.
Yeah, after chemotherapy, if you are talking about bladder cancer, we were using this docetaxel and oxaliplatin. This we were using as second line. Dr. Advani, I learned it from Dr. Advani from Bombay when I referred few patients, and then we started using that. So there are trials for that. And that second line after chemotherapy, like for prostate, you give docetaxel and then you give the cabazitaxel. So these issues are there, but because the immunotherapy is less problematic, it has less side effects, and that is the recess after chemotherapy, when you want patient to be safe, the quality of life to improve, and chance that complete remission can be there, and immune check inhibitors are giving that, and therefore it has been tried, and as second line after immune check inhibitors, you can give the chemotherapy. After chemotherapy, you can give, if first line, you can give immune check inhibitors.
I think the last that he quoted the CA prostate stampede trial, and in which we had multiple arms, and now it has almost become a standard of care that upfront chemotherapy along with hormonal therapy is the standard of care for metastatic CA prostate. And now again, in the another arm, it was abiraterone, upfront abiraterone with hormonal therapy. And then the profound trial where they give the olaparib or the PARP inhibitor, particularly in patient who had BRCA2 gene in them. So any comments on the, yes.
Yes, you are right. In various arms, like you talked about these various arms where zoldronic.
Signal is a bit yes. Yeah, please go ahead.
Like this.
Yeah. Yes, please go ahead.
Yeah, various arms are very beautifully in Stampede has been studied. And when you talk about zoledronic acid is accepted everywhere, because before this, this is third generation. Second generation were Pamirad, Pamindronate, and Bondronate came in between. So these all compounds came, we settled on zoledronic acid. Then there were studies, zoledronic acid versus your this XG, what is that? Yeah, this denosumab. So denosumab was shown to be beneficial for overall survival improvement, maybe slight, but zoledronic acid was to delay the skeletal events. And later on, it was thought that in castration-resistant prostate cancer, in metastatic disease, we should add regularly zoledronic acid. But this study has shown the importance of zoledronic acid is not there to improve, and universally it should not be added to the treatment as standard of care. So that is one. The second thing is that when you talk about abiraterone, we know that only testosterone or dihydrotestosterone are not only the androgens. There are so many androgens which are to be prevented, and abiraterone is acting at multiple levels. And what happens in the tumor, prostate tumor, that it becomes self-regulatory. I mean, when it becomes castration resistant, because the cells there in the microenvironment inside the tumor, there itself the formation of this testosterone start. Or the other androgens which are promoting the cancer, and there this abiraterone act. So if we start upfront, it was the theory, it was postulated, and ultimately it has been proven that because of the cost is there, because once you start, you have to give it for long time, but you are giving along with prednisolone, that is beneficial to curtail the side effects also, and therefore this arm has shown the benefit, and it can be continued even before the castration resistance occur, or even before the autoregulation of the tumor cells start. So if we add, and it has been proven now that it is beneficial. Now coming to olaparib. Olaparib is the gene repairing thing. And you know that immune check inhibitors are not very effective in CA prostate. CA prostate, when we go for PDL1 testing, mostly it is, so because the one indication of pembrolizumab is that you can give in solid cancers, where PDL1 positive patients are there. But that testing has also shown that it is not that beneficial, and it came, US FDA had given limited approval in 2017 and for immune check inhibitors in that, but that was not that effective. But olaparib is proving to be very, very effective. It is the gene repairing, and the apoptosis is restored in the cells, and it actually, like Caesar, it removes the defective part and it replaces. Olaparib is very costly. When you were talking about cost, it is costing around 5 lakh rupees of one injection, and and when we write it for the urological indications, it is not, we are not getting it, because it is for each indication. DCGI, the Drug Controller General of India, there you have to submit either the trial or exemption application. They have not submitted till now. So this is available for other indications under insurance also, but for prostate cancer, where it is very, very effective, we are not able to use it much. I have used only in one patient, and that patient also I lost. So experience I cannot explain to you, that in Indian population, because genetic makeup of various races can also differ. So in India, the general approval by DCGI is not given like that. I am the member there, but question is that our genetic makeup is different, and then this testing is required. If BRCA1, BRCA2, and this testing is germline testing, which is now part of US FDA, the recommendation, that is important for high risk patients, and whether these drugs are going to be useful or not. BRCA2, if that is positive, then instead of using this at the end, these drugs, immune check inhibitors also, these all should be used upfront. As you remember that dendritic cell therapy came, 50 lakh rupees.
Right,
But,
right.
but
Yeah.
people were giving it in the terminal stage. But US recommendation was that at very early stage it is to be given. So these costly therapies are not affordable. We are not able to use it, but scientifically or for the academic interest, they are the best choice for complete remissions, long-term survivals. So these are very important in
Yes,
professional work.
yes. Sifileucel T and that immune
So
vaccines
that
were.
has gone totally now, because that it was given in that stage where now we say that observation is the best policy. Very
Right.
early, asymptomatic castration resistance, very early. So there we were giving immediately that. But now immune check inhibitors have come. They are cheaper than that. And therefore in 2012, when it was approved ultimately after 3 attempts, the stipule C, which was dendritic cell therapy. In
Yeah.
2012, it was approved, and it was not approved 3 times by US FDA. Ultimately, it was approved, but not for the terminally sick. It was approved for the early patients. And it is CA prostate is a disease of advanced age. In advanced age, when you do apheresis is when you remove the blood. You first induce the white cell formation, then you remove the blood and separate the white cells, and then induce them to the tumor cells in the presence of cytokines to produce dendritic cells, and then reinfuse it. So this all process which was given, so the basic, there a controversy came that when old age frail patients, you are removing the blood and doing apheresis, their overall health and survival is being affected.
Compromised. Yeah.
So that was the another thing, because it has gone out of focus, and now nobody is using it.
Right.
Only duplicates are available in India. There are many companies. 2 companies are in India who are providing dendritic cells, and there are 500 companies in China who are still providing dendritic cells by this process. But we are not using, because immune check inhibitors have sidelined all other agents.
And some of the studies even have combined docetaxel with abiraterone and sometimes even with enzalutamide as an upfront chemotherapy in particularly young patients who have CA prostate, advanced CA prostate or
Actually,
metastasis.
there are 2 things. What is the sequencing of therapy in oncology? Another is the combination.
Combination,
Why
yes.
we stopped combined androgen blockage? Because it is giving survival advantage, but more toxicities.
Yes.
So we have to weigh. Similarly, now a new trend has come that immune check inhibitors, if you can combine, then the toxicities, if are not increasing, then the benefits of 2 mechanisms you can take. Why we are not combining? Because we don't want toxicities. If toxicities are controlled and overall survival weighs in favor of this, we can combine any combination. I'll tell you that flutamide, bicalutamide, these were there, and nilutamide was there. Nilutamide, there was a night blindness. But ultimately, what has happened, the mechanism is that androgen receptor is there. Flutamide and bicalutamide say act on this end, and nilutamide act on this end, and then enzalutamide also act on this end. So that's why once flutamide and bicalutamide fail, you start getting benefit from nilutamide. And that's why in my clinical practice, when I feel that now bicalutamide is not working, so I shift to for cheaper alternative, not to enzalutamide, but nilutamide. And similarly, Honwan, that is used, that is again being studied. So this all is an ongoing process. Whatever we are discussing today will not be relevant after say 6 months or 1 year.
Right. it's changing so rapidly.
Yeah.
But definitely immunotherapy is coming in a big way, and maybe in the near future it may replace chemotherapy in a considerable way. So,
Considerable way, and side effects are less. So people
yeah,
will prefer once the cost is controlled.
cost is controlled. So, if any of the faculty member residents, or particularly third year residents who are appearing for the exams just maybe in a few weeks, do you have any question? Because these studies are very important, not only from clinical point of view, but from examination point of view also, because many of the examiners would be interested in asking you these studies, which
At
have
least,
changed the treatment. Yes.
at least concept should be there so that
Yes.
the examiner understand that you have the concept.
Right,
You may
right.
not have the practical experience or the first-hand experience, but you have the concept and you know what is immune check inhibitors. There are questions in the theory, there are questions in the viva. Today also, whole day, I was the examiner for Odisha Hota Center. 5 students were appearing. And
Yeah.
we were almost in every case, certain elements of these things come directly, indirectly, because of discussion that what you will do, neoadjuvant chemotherapy, neoadjuvant work therapy you will give. Then if somebody is not saying immune check inhibitors are also there, like
Yeah.
I'll tell you that after surgery, what you are doing. If
Yeah.
the progressive disease is there, like surgery for radical cystectomy, and
Yeah.
after that, if it is non-progressive disease, you don't give anything. But progression is there, then you give immunotherapy. Then there was a trial. Pfizer came with avelumab, another monoclonal antibodies, and now it has been proven that the progression is delayed if you use avelumab. So now it is in the Indian market also, and we are going to start. Merck is marketing it. It is also costing, I think, 1.5 lakh rupees. But the basic problem is cost. But for how long this cost will continue? Ultimately, the patent period has to be over. It is over now for Sutent. It is over almost all those generation drugs, and they one day will be there when these drugs will also be available freely.
So, are you aware of any of the clinical trials going on in particularly any of these malignancies with immune?
Many are in the pipeline, but they have not initiated. They had not submitted. Many are coming. Many are coming.
Right, because
Because of the COVID scenario, what we were doing, that even that like we were giving docetaxel, we switched it to abiraterone or enzalutamide. We were trying that patients don't come for even IV therapy. So these all immunotherapies are IV therapies. We tried to postpone it. Even one trial which is with me on the that was PK sampling for new drug Votrient, the comparator of Votrient, Indian had come. So they had to do 45 patients, and they are still to go do 36 patients even after 1.5 years. So now they have taken my center also for PK studies, plasma concentration studies. So this period is difficult for trials also, especially those are investigational agents are IV. If IV requirement is not there, that for tablets the patients were not visiting hospitals. So all kind of trials have suffered, but immune check trials is the next trial, and combination therapies.
right,
What
right.
you are mentioning.
So, one of our third year residents has asked about the cost of nivolumab. Whether this 1.4 lakh that you said was the cost of nivolumab alone, or it was a combination of nivolumab and ipilimumab.
No, ipilimumab is very costly. I told you that monotherapy also we are giving, and that is quite effective. And nivolumab, which is 1.4 for one injection, if you give for a month, after 15 days repeat, that dose is free. So it is monthly cost.
So, how long you give it for the duration?
There are no definite studies that till progression it is to be given, or till 2 years it is to be given. But then the side effects of immunotherapy also start after 1.5 years or so. And because of multiple endocrinopathies. So therefore you have to be balanced, and we stop it after 2 years if we can. But if there are no side effects, if we are able to control in one patient, my 4th year is going to complete, and patient is who was a big renal tumor. He had the bone metastasis, he had the lung metastasis, and I was surprised that he was playing cricket.
Okay, that's great. So what about cytoreductive nephrectomy now? Do you give upfront only this immunotherapy, or after cytoreductive nephrectomy?
Upfront, see, my many things I am able to afford. I am not recommending that, though, because there are experimental I keep on doing, because drug is freely available, and our patients are not like Sutent and Votrient are also. I have made it free in my hospital, originals. So that is effort. You cannot give to every patient, but yes, if you can, if given choice, I'll give it before also as new admin.
Cytoreductive nephrectomy.
It is not recommended. It is not in the guidelines.
All right, because nowadays people are upfront giving this immune checkpoint inhibitors also.
They are giving, and what has happened, the level 4 thrombus, IVC thrombus became level 3, and the whole surgery changed in one of my case. So I'm giving.
Right.
Off level, not residents, not recommending for the resident.
Yeah. So if any of the faculty and residents do not have any question or any comment, so we would wrap up the session now. Thank you, sir. Thank you, Dr. Sood. Once again, it was a wonderful interaction, and I am sure the residents must have been benefited a lot. And this was especially for the third-year residents who are going for the final exams now. So thank you once again, and thanks all the viewers who have joined us today.
I'm grateful to all of you for giving me chance to interact. I'm going back to the exam because Ramesh is there. He is not finishing the exam. He told you go for some time and come back. 5 students are there. So I'm thankful to you all. And for residents, they should not get scared. These are all discussed because you should have concept that these things exist, and you should be able to answer something.
Thank you, sir. Thank you.
Thank you, sir. Good night, sir.
Good night. Nachiket, any comment from your side? And just your last comment, yes.
Nisa, I think that we've had a great discussion with sir, and as we all know, he has immense knowledge, and he uses immunotherapy for all malignancies. Very regularly, and on account of his efforts, so much of these immunotherapies are available in RML for even common patients, and I'm sure that the residents have benefited. And we thank sir for taking the time out. He was busy inside the exam. Now he again has to go inside the exam. It's always a pleasure listening to you, sir, and you're a teacher of teachers for all of us. And thank you so much for coming, and till we meet again, until you come again inside the class. Thank you so much.
Thank you. It is my privilege, and thank you very much for this opportunity.
Thank you, sir. Bye-bye, sir. Good night, sir.